so we can talk about different stuff. Let's see, here we go. There we go. So in your postural analysis, we'll actually ask you to take a picture of a family member or yourself or something so that you can actually do this off a real live person. But when we see that person, then we need to label their posture, and we don't actually use terms like hollow back, flat pelvis, slumping posture, military posture. You might hear me use those things, but we don't use them with clients. We don't really describe people that way. So let's look though at this orange gentleman on the left who apparently has a hollow back. What I see in this picture, to give you an idea, is I see an anteriorly tilted pelvis because his pelvis is actually going forward and down. You can see that because the line underneath it's actually tilted more forward. That makes his bottom jet out, his stomach jet out, and his shoulders jet out, believe it or not. Anterior tilts of your pelvis create exaggerated curves of the spine. So if I describe this posture, I would say this person seems to have an anteriorly tilted pelvis, an exaggerated curve of their lumbar curve and their thoracic curve and their cervical curve. It seems to me like their neck is bent more, their back is bent more, their low back is actually bent more. They have all the curves they're supposed to have. The curves are exaggerated. And this is very common in an anterior tilt. So this may not happen with somebody you take a picture of, but this is textbook common what happens. When pelvises tilt forward like this, it makes people's butts jet out, and believe it or not, your body wants to get back over its legs, and so it exaggerates the curve of your low back to try to get you there, exaggerates your neck to try to get you back over your hips. So this hollow back, which I've never heard it called this before, by the way, but this posture here of this hollow back is one of the most common things we see from sitting at a desk. Somebody sits there and they develop this thing because their hip flexors get shortened. So first in this homework assignment, let's say you took a picture of your little sister and this is what she looks like, but she's not orange. Well, if she's orange, that's okay. We don't judge that either. But this is what she looks like. And then you would say she's got an anteriorly tilted pelvis, an exaggerated lumbar curve of her spine, exaggerated thoracic curve, exaggerated cervical curve. And to be honest with you, I don't really see anything else on that person that's noticeable, right? Let's look at flat pelvis. This person does not have an anterior tilt, believe it or not. I know you see a little bit of one there, but that's actually not much of an anterior tilt. Everybody has a slight anterior tilt. And so this person actually has probably a slightly posteriorly tilted pelvis, which is removing the curve from their lumbar region. So they lack proper curve in their lumbar region. And I don't know why, because a lot of this you won't know why either, and we don't know why, but for some reason too, this person's neck is in a flexion too. So for some reason they are standing like this. Their head is down. That's in a flexion. So I would describe this as, lack of lumbar curve, flexion of the cervical region. And there's not one right answer for all this stuff necessarily, everybody. If we look at military posture, which looks like it should be ideal, military posture comes from a posteriorly rotated pelvis. And when that happens, the lumbar curve and the thoracic curve and the cervical curve start to disappear. And that's not good either. So this person lacks normal curvature of the spine. And then on rounded shoulder, those hips look about right. The lumbar maybe is right. It's really hard to tell. What do they have? They have a super exaggerated curve of the thoracic region. Kind of a hunchback look. And that's called kyphosis, by the way. But it's an exaggerated curve of the lumbar region. This person probably has rolled in shoulders and they're kind of hunched over like this. That'd be my guess. And that's why they're just calling it rounded shoulder. But again, these names are not correct names for anything. These are just slangy names. I want to know, when you're looking at this thing, can you describe what you're looking at? Yes, Miss Routson.
Sorry to just jump in there like that.
No.
One of the
I want you to.
one of the first people that I had right off the bat in clinic had kyphosis. I don't know if I said that right.
Yeah.
My question is, do we use a lot of pressure on them? Is that something that hurts their spine? Like, is it appropriate to try and get in there a little bit?
Yeah.
At what level is it, like, too aggressive? I think I might have been a little too aggressive.
It's not about the posture of it being too aggressive for the posture. It's just about if you think the person can take it. So, like, sometimes we see this kyphosis in people that are 98 years old. They've kind of been hunched over their whole life. And yes, I'm not going to try to correct the posture of a 98-year-old person because they've probably been that way for 60 years, and that might do damage. But if you think their tissue looks healthy and you think that you can get in there, go for it. You can open that up. Yeah. Yeah,
okay,
it's okay.
So I just, if that was a contraindication to doing deep pressure and trying to work it. I mean, obviously you're not going to correct it, but just, like, being more
Now,
aggressive.
what I would be a little bit careful of is it's very common for people with osteoporosis to get that kind of hunched back look.
Okay.
And so if they had some type of bone degenerative thing, then I would not be pressed on them as hard.
Okay.
And the only way to know that is to kind of ask them. And just to look at, did they look frail?
Okay. Like person to person.
Yeah.
Kind of like my other jobs I've had where you take it all in at first.
Yeah, I mean, number one with everybody, I'm looking at, like, just how healthy does this person look?
Okay.
Yeah. I'm like, if I walked around the block with this person, would they be catching their breath? That worries me. But if that looks pretty good, and then their skin looks like, it looks like it's going to snap back, and they had a little massage before, then yeah, you're probably okay.
Okay, cool. Thank you.
Yeah. Cool. So let's look at the postures on the right. Now these are looking at the spine. These are looking at your body left to right, really, to look at balance. Okay? And the one that says high shoulder, we would describe that as an elevation of the right shoulder. This person's doing this. Now, I would argue this person's doing this too. So I would describe this person as elevated right shoulder. Is that? Yep, elevated right shoulder. I want to make sure it's done. And flexion of the neck to the left. That's it. That's all I really see. Let's look at high hip. I love high hip. High hip really means we put a transverse plane through the hips and one hip is up high. Usually, when that happens, you get a lateral curve of the spine because my body wants to get my shoulders back over my hip. And this guy's got it. As you go up, he leans over to the left side because he's got to get his neck and shoulders back over his hip. So you would say lateral tilt of the hip on the left side, it's elevated, and a flexion of the spine, a lateral flexion of the spine to the left too to correct this. You're just trying to describe an image, not why it's that way. We don't care yet. And then let's look at severe scoliosis. It would be totally correct to call this scoliosis. You'd say we've got scoliosis here with with lateral curves of the spine. You're not supposed to have any lateral curves of the spine. And because of the scoliosis, there might be, it's kind of hard to tell from this picture, but there might be, scoliosis often causes an elevated shoulder, an elevated hip, and quite often it's opposite. Quite often this shoulder comes up and my left hip comes up, or the opposite, because my body's trying to balance back. So what we're trying to describe, people, is in two big pictures. And those two big pictures are, when you cut my body with the mid-sagittal plane, When you cut my body with the mid-sagittal plane, you are looking at it as though these pictures on the right. You are looking at my evenness from left to right, my spine from left to right. When you cut my body with the frontal plane from front to back, you're checking if my hips are poking out back here or here where my shoulders are. You're checking out the stuff we see on the left of this picture. And when you use a transverse plane, you're looking for things like, is this shoulder up higher than that one? Or is this hip up higher than that one? We're looking for that kind of level. Now that was a lot actually that I just threw at you. So this is why we have a plumb line in the lab, because we'll drop it down and we'll use it to look at you mid-sagittal, left and right, are you in that line? Frontal, front to back, are you staying over that line? And then some transverse stuff, mainly at the hips and shoulders, to see if they're even. In fact, looking at my shoulders, I feel like this one's up a little bit. But anyway, I'm a mess. Anyway, so the first part of that assignment would be to take a picture of somebody from the side and from the front, clothed. From the side, but clothed. I'm sorry, I just thought maybe I better be clear. Clothed. But it'd be good, by the way, if they're not wearing a muumuu and we can't see their shoulders and hips. But anyway, front and side. And we don't need to know who they are, and it can be you anyway. And then describe the posture. Cool? Then we want to figure out what's going on with that posture, right? So, let me stop sharing this really quick. So then we might look at stuff like, okay, how did this person possibly get here? And this is the stuff that we won't have an exact answer for. Like, I don't know if the low back problems cause the neck problems or neck problems cause the low back problems. So you're just going to tell me how to make all that stuff better. And what we're looking for is this type of stuff here. If we have, can you guys see the whiteboard yet? All right. If we have what I would call anteriorly rotated hips here, they're kind of tilting down this way, then what, I don't even know how to ask this question. Where might I find shortened muscles that cause this posture? What muscles could cause an anterior tilt of the hip? And by the way, you have not learned all these, so don't feel like this is why we just started introducing this now. But if it's pulled in front, we're looking for stuff in front. And so, which quad goes across two joints?
Rectus femoris.
Yes, rectus femoris. So that's a hip flexor I would check on this person, right? We also talked about a weird muscle that's kind of like inside your low back and down on your hip, and one that's inside your hip. And both of them go down here. We talk about them together. Anybody know what that muscle is? It's two muscles that we call one name.
Psoas.
Yes, iliopsoas. Iliacus and psoas major. And those are hip flexors too. So that would be good stuff to list, right? And you will find other ones, but things, believe it or not, the tensor fascia lata is in front. It can be a hip flexor. It can cause, you're looking for anything that can cause an anterior tilt. And to be very honest with you, there's some sneaky stuff you can do to look this up. In your guys' book, this is a good book. Usually in the beginning of every section, like I'm going to pelvis and such, just bear with me a second. After they get through the bones, I think, hold on, I could be telling you wrong. Well, hold on, bear with me. There we are. Ah, here we go, sorry. After you get through the bone section of your book, you've got something called synergist. Synergists are muscles that work together. So, if we look for flexion of the coxal, flexion of the hip joint, it lists psoas major, iliacus, tensor fascia lata. These would all be culprits of that, right? And so those are really easy things for you to be like, these could be possible shortened muscles that could be causing this. Now, will you know? No. Will Tapscott know? No, I won't. We'd have to actually massage this person, and we're not going. Well, you might, but I'm not going to. So we are looking though for what might cause that. Now, one thing I want to not caution you is don't stop here, because we also know that the muscles in here, this low back, have to be shortened too, because it got pulled together. And so we might say, hey, the extensors of the vertebrae, longissimus, iliocostalis, spinalis, maybe quadratus lumborum back there is pulling those hips in a really tight area. The beauty of this is we still don't walk away knowing which caused which, but we know now a systematic way to approach this client. Because we're going to try to fix the anterior tilt. We're going to try to fix the lumbar extreme curvature. If there's extreme kyphosis, which is upper back, that could be abdominals. The abdominals could be pulling down like this. So we would work these things, and it would be a very good place to start with somebody. And by the way, sometimes it's a place to finish with somebody. Sometimes this is enough. Because what happens is this person comes into the office complaining of like a neck problem. So, and those muscles will be shortened too if they're like this. Those are shortened. So you would tell me some neck muscles that you guys have memorized, like splenius capitis, semispinalis capitis, splenius cervicis, trapezius. Anyway, you would loosen those, and most massage therapists do that because the person's complaining of the neck, but you guys have gone to Gateway, and you would also loosen the low back and the hip flexors, and now this person actually might have the posture down below to allow their neck to stay good. And so that's why we do this exercise. So we're trying to train you to use things like flexion, extension, adduction, abduction, supination, elevation, all these things to describe a posture. And if it feels hard when you guys do this, it should. It's really hard to do. Because those big orange pictures and blue pictures, those are really obvious mistakes. Most people have little stuff like this, where you're like, is your head tilted to the right? Is that shoulder a little bit up? I'm not quite sure. And we get that. Don't worry, I'm not going to get nitpicky with you. Just be like, yeah, it looks like it could be. And you label that stuff. And then you say, well, what could cause that? And then you list those muscles and you say, I would stretch these muscles or massage them, because in general, that's what we do to lengthen them. So we're looking for the shortened muscles that cause the problem, and that's what we do to lengthen them. Once you've labeled the posture and you've identified the muscles, you're pretty much done, because then you just say, I would massage those and lengthen those muscles. Or fascia. I don't know if it's the IT band or something. And that's it. Now, I know you don't know what you don't know, but having not seen the project, does that kind of make sense a little bit? Maybe? Miss Mejia, do you have a question? You had the almost, I'm going to ask a question look on your face. And you'd be asking for other people that are probably wondering too. And
well, I don't know if that would work for someone who's had spine surgery, like my mom, to try to fix it, because it's still, like, her posture's not good still. But I was like, well, it's not really anything that can be fixed because the muscles have already been messed up from the surgery. I mean, you can, like, help a little bit, but I don't think, so that's what I was kind of thinking.
I'm glad you thought
it.
So,
yeah.
So just not to, by the way, I asked you to speak up and I'm glad you did, but just not to confuse anybody, we're keeping it simpler than that. Like, we're pretending that we could, right? But, no, I know, I asked you. But what Ms. Mejia brought up that's really important, and we will talk about later, is what we call functional adaptation. And that means, like, let's take her mom, for example, which I don't know exactly what surgery she's had, but she's had to adapt. Some of the surgery is permanent, right? Let's say that she fused some vertebrae or they put a rod in somewhere or whatever. She's now had to adapt to that, and her muscles have done certain things to adapt to that, and changing those things is not necessarily a good idea. You're right. There are times we look at somebody and we go, oh, you're kind of like this, but you've been like that 25 years, and this seems to be working for you. Like, you're right. There are certain things we don't try to change, and we can't change the length of a bone, things like that. And in those situations like your mother, we would still gain something from this, which is we'd probably be able to identify the muscles that are bothering her the most. But you're right, we're not necessarily trying to put her back to factory reset. So you bring up a really good point. And that's a very hard decision to make. Like, how far do I push this client? Some of it we just kind of see how they progress. But I hate to say, there will be clients that you guys have where your job is just to relieve discomfort. You'll do it better than anything else they can find, but you're not going to get them back to normal, for lack of a better term. Yeah. Thank you. Thank you.
I was like, trail, I don't know.
Yeah, you were thinking.
Wondering, but still like, you know. So I didn't want to say anything because I was like, well, it's not really 100% on top.
Well, it's very on topic. It is very on topic because you could do the best postural analysis ever on somebody, and you're right, it doesn't matter. They've got rods in their back. Like, what are we going to do? I'm not going to try to change the rods, so you're absolutely right. Yeah. All right. So let's